Hello everyone. Today I want to try a new thing out, something called a virtual case conference where we do some asynchronous learning through a case. First, we'll start out with our clinical dilemma. We took care of a 42-year-old man who's coming in for a reduced sternotomy commando procedure and ascending aorta replacement. The patient had a history of IV drug abuse, particularly heroin. Here are some starting vitals and labs. You can see that our patient is normotensive, tachycardic, with a little bit elevated, an end tidal of 41. Our PCO2 is also a little elevated at 46, but other than that, pretty unremarkable. We attributed at this point his tachycardia. He was a young, relatively healthy male with a history of IV drug abuse, so we thought we were inadequately managing his pain. So we worked on better managing that. About an hour and a half into the case, things started changing. One, we were getting more hypertensive and tachycardic. Once again, we attributed this to poorly managed pain control. However, at this point, the patient was on about a MAC and a half of isoflurane, and we had started 5 of nicardipine. Additionally, his minute ventilation had increased to 9.4 liters per minute, and his end tidal CO2 had risen to 51. And I had noticed the resident kept adjusting the respiratory rate to increase our minute ventilation. So at this point, I asked him to grab a gas. So you can see we have a respiratory acidosis, or PCO2 is 62. So at that point, I'm thinking, hey, maybe this hypertension tachycardia isn't poorly controlled pain or inadequate anesthesia. Maybe I have to be worried about something else. Do I have to be worried about MH? Having never seen MH myself before, I phoned a friend, as we should all do when we're not sure what's going on. He said, I think you're being reasonable. I think it could definitely be MH. Other things in my differential are listed here. Essentially anything that is unexplained hypertension and tachycardia. You see in the list is illicit substance abuse, but that's more acute intoxication with like cocaine, methamphetamine, something like that, not our patient's history of IV drug abuse. At this point, I was pretty convinced it was MH, but I did call the mHouse hotline, as all of us should do if we're worried about a case of MH. Spoke to a wonderful physician on the phone who guided me through the diagnosis and treatment. She agreed with my diagnosis, and together we made the decision to give dantrolene. At our institution, we have Ryanodex, so we actually only needed to give 4.5 cc's of medication. To my surprise, dantrolene is bright orange, which is why I included the picture, because I would have never guessed that. And as soon as we gave them dantrolene, things got better. Our heart rate came down, our blood pressure came down, which was confounded by the fact that we also gave metoprolol. But most importantly, our end tidal CO2 came down within minutes. And on the next slide, I'll show you the gas, but it was pretty impressive. In addition to this, we put the patient on 100% FiO2 and ventilated them, increased the fresh glass flows to 10 liters a minute to wash out all the inhaled agents. We also put charcoal filters on our ventilator, and we stopped all calcium channel blockers, as that can worsen the MH crisis. So here's what our gas looked like 8 minutes after dantrolene. You can see it looks pretty normal. Our PCO2 went from 63 to 44. Our end tidal, as you can see, went from, I believe it was high 50s by the time we gave the dantrolene to 34. And like I mentioned, our heart rate and BP came down as well. So one question you might have is, what do we do in the case? Well, as soon as I was worried about MH, I told the surgeon. I let her know that we were worried. She immediately put her instruments down and said, well, we're not cannulated. We're in a place where we can stop and go upstairs. If you think it's MH, we're treating for MH. We're not going to do this case today. Fortunately, it was before they were cannulated for bypass, as it was a reduced sternotomy, so it did take them some time to dissect down. And that's what we did. They closed up pretty quickly, and we took the patient upstairs. Unfortunately, about a week later, he had a non-triggering anesthetic and did very, very well. So today I learned you might actually see MH. It's not something that you'll never see. One thing that I was worried about when taking care of this patient, I was like, I must be wrong, because he already had a previous sternotomy, so he had an anesthetic and didn't have MH. However, I learned through my quick research that about 50% of patients had a previously normal anesthetic, so that reassured me that I could still be on the right track. Just as a reminder, MH is due to an abnormal ryanodine receptor. It causes the release of calcium from the SR, resulting in uncontrolled muscle contractions and increased aerobic and anaerobic metabolism. So yeah, this is our first case conference. Hopefully you guys like it. And just a little snippet about MH. It's a very rare case, but an important one to get right, as it can be very, very dangerous and have devastating consequences for our patients. So thanks very much. Bye.